Today's speaker is Dr. KIRK SAHAGIAN. Dr. SAHAGIAN received his undergraduate degree from Holy Cross and medical degree from the University of New England. He did his surgical training at the William Beaumont Army Medical Center and then did further training in bariatric surgery. He was a staff surgeon in Fort Campbell, Kentucky, and then director of their bariatric surgery program. He spent time in Afghanistan and Iraq prior to going to the Gateway Medical Center in Tennessee. He came to Maine in 2015 and has been at MMC since 2017 as part of the Weight and Wellness Program. He is currently the Associate Medical Director of the Minimally Invasive Surgery section of the Division of General Surgery here. So good morning and welcome to Dr. SAHAGIAN.
Thank you. You don't want to give people a couple more minutes? I think I'm going to do that. I'll give them like 5 more minutes because we can definitely get done in time. So I'll wait till about 9:10 if no one minds. Oh, someone smarter than me has shown me that there are actually 63 participants. So maybe we should get going. So thank you for inviting me to give you a little bit of insight onto our weight and wellness program. It's certainly something that's near and dear to me and also treating obese patients. So maybe the most important slide you're going to see today. This is what you text so that you can prove that you attended the presentation. So I'll leave that there for about, well, a couple of minutes here, or maybe a minute. I'm going to show this slide again at the end too, so people who come in will be able to use it later. So we'll move on. So what are the objectives for today? So the first thing that we're going to talk about is the price of a passive and ineffective approach to the treatment of obesity. And we'll talk about that. First, just outlining the true and intense problem that we have with obesity across our nation, and then also specifically what costs to society does obesity cause? Then I'm going to introduce the weight and wellness team, and also finally the weight and wellness philosophy and approach to care. All right, so let's jump right into the price of a passive and effective approach to the treatment of obesity. So first we need to define it. So what is obesity for the purposes of our talk today, for our discussion? And first, in adults, obesity is a body mass index of 30 to 39.9. And I list these comorbidities so that we can sort of get an idea of who would potentially be a surgical candidate. Because at this BMI, you would need comorbid illnesses usually to qualify. And some of the comorbid illnesses are listed there, including diabetes, sleep apnea, GERD, and so on. For severe obesity, you would have a BMI of greater than 40 in adults. And for adults who are at that BMI and their insurance covers surgery, they would qualify. For children and adolescents, it's slightly different, but I tried to paint the same picture. And in comparing these two, so for class 2 obesity, you'd have a child or adolescent who's 120% of the 95th percentile on a weight chart, or a BMI of greater than 35. Comorbid illnesses that we look at for adolescents for surgical candidates include this list here. So many of the similar diseases that we take into account in adults: diabetes, sleep apnea, others like NASH, Blount disease, GERD, hypertension. And then for someone with more significant obesity, class 3, that would be 140% of the 95th percentile, or a BMI of 40. So in many ways, pretty similar to adults. So what are we dealing with? And you can see here, these are data that were collected by the CDC from the 60s until really pretty much now. And we see a very steady incline to our graph amongst all ages. And these are ages from 2 to 19 years of age. And unfortunately, we're getting to a level for many of these ages in the 20 to 25% range incidence of obesity, which is amazing to me. And what does that translate to in actual numbers of people? Well, it's roughly 4.5 million adolescents in the US are affected by severe obesity, which is really just an incredible number. Overweight adolescents have a 70% chance of becoming overweight as obese adults, and they have an 80% chance if their parents are overweight. About half of obese teenage girls and a third of obese teenage boys become severely obese by the time they're 30. And 1 in 12 teenagers become severely obese or 100 pounds above their ideal body weight as they enter adulthood. And this is proven in the data. So here we are with adults. What's the rates of obesity in our adult population in the United States? This is from the year 2000 to 2018, and unfortunately, the story is the same. So it's steady incline in the percentage of obesity from 30 to now, amazingly, 42% of adults in the United States are obese. And maybe more importantly, severe obesity is now reaching nearly 10% in the adult population in our society. Another way of looking at this, I like this slide because it makes a prediction. So you can see, again, we have data from the 60s all the way until now. And they also project what the degree of obesity amongst adults in this age group would be in 2030, which is not very long away. And it's projected to be 50%. So we are a country of roughly 300 million people. Not all of those are adults, but let's just be conservative and say that's 70 to 100 million people. So it's obviously a very significant issue in society, and we need to develop aggressive, effective treatments and also preventative measures to deal with this. So just to talk a little specifically about cancer for a moment and obesity, people probably know this, but there are several cancers that are related to obesity, and they're listed here. So they include esophageal, pancreas, colon, rectum, breast, endometrium, and so on and so forth. It's known that excess weight and the lack of sufficient physical activity can cause between basically a third of common cancers in the US. And that was determined by the International Agency for Research on Cancer. So it is a very significant link in many cancers in our society. So another way to look at the cost of obesity in our society is looking at what is killing people annually in the United States. And I won't choose these randomly. So these data have not changed for roughly 15 years. If you look at 2010 and even before then, it looks very similar. The difference this year, of course, is our enemy of today, COVID-19. But heart disease, cancer, diabetes, and stroke have been there for a long time. And I'll show you this in a different way. So this is Minnesota in 2010, but the numbers are the same. So it's diabetes, stroke, heart disease, and cancer, the same four. This is over 50% of deaths in our society in the United States annually, and it has been again for many, many years. These are all obesity-related chronic diseases. So really, I think we talk with our patients significantly about all of these things. It's a big deal if we have a patient with diabetes or has cancer or heart disease or they have had a stroke. We don't necessarily talk about obesity as much as we should. I can't tell you how many patients we see in our clinic who don't even have obesity listed on their problem list. And obviously it's a major player in some of these diseases that we pay more attention to. What's another cost? Well, actual dollars. So here we have the Society of Actuaries showing that obesity costs the US about $270 billion. This was actually in 2013. When you look at data now, it's up in the 400 billion range. And what is $400 billion? It's hard to sort of quantify. It's a massive number is what it is, okay? And more importantly, what does it mean? So why is this? And the reason it is because patients who are obese, they need more medical care. And unfortunately, they spend more time in hospitals. They also spend more time off work, and that decreases their economic productivity. They die sooner than they should. When you look at an obese teenager into adulthood, they can expect to lose roughly 10 years of their lifespan if they spend most of their life obese. So excess mortality and also disability. So where are we now? The incidence of obesity is worsening. Obesity-related illness is associated with greater than 50% of deaths in the United States annually. And as you've seen, it's at a tremendous cost in lives and actual dollars. So why are we losing the battle? So this is probably an oversimplification. It's not just one thing, but this is a major thing in why we are losing the battle. Very few patients actually get care. So this is just another way of looking at obesity from a perspective of population health. You see obesity as a disease and how many people have it. You see BMIs of 30, and then we get to more sick folks, people who have higher BMIs and more comorbid illness. And then if you look at the overall numbers, and then look at these very small areas that represent how many patients are actually getting bariatric surgery for their disease. It's a very small number. And also another very small number is patients who receive anti-obesity medications for their disease. And these are the two most effective therapies that we have in our arsenal right now. And not enough patients are getting them. These are data from the ASMBS. Not over 90% of surgeries in the United States are now done at accredited centers like ours. So we have a very good idea of how many cases that we are doing. Take my word for it, 2011 to 2018, that's about 1.7 million cases done. It seems like a lot, but what we know is there's roughly 24 million adults who would qualify right now. So we've barely scratched the surface, okay? And actually, let me go back to this for a second. For adolescents who have had surgery, the best data that I could find was less than 2,000 cases annually. And as I told you, there's now 4.5 million adolescents who are severely obese. So, I think that's something that we really have to take into consideration. We need to really start trying to be more aggressive with adolescents, with children, with adults. So what have we learned when we actually attempted to tackle obesity head on with an adult patient? So first, there needs to be sort of really a fundamental approach to this. And it always starts with looking at what can we do to potentially change behaviors that are counterproductive to patients losing weight and gaining health. That's the first part of this. And we have to do that with all of our patients, and we always have. And then we go up the pyramid to other strategies that have become more in the forefront today, which definitely include medications and, of course, surgery. But all of these things together are usually needed for the patients that are referred to our program. So now we're going to get into looking at what are possible strategies to treat obesity. And we'll look first into behavioral. Here we have the pounds lost study. This is basically looking at what are people eating. And this is a group of patients who had a specific gene, adults, tendency towards obesity. And they studied them by feeding these patients 4 wildly different diets as far as the content of carbohydrate, fat, and protein. Initially, the focus was calorie restriction, and then there was a maintenance phase. And what we can see after 2 years is, unfortunately, the results, they're not as good as probably we would like. When we look at the total weight loss, it's anywhere from 2 to 4 kilograms, which, that's less than 10 pounds. So for patients that we're talking about, this is not going to be an effective strategy against their obesity. So what other options do we have? So pharmaceuticals have definitely come much further into the forefront, although I wish we had 50 medications or 100 medications that we could use. For adults, we have 9, and for children, I think we only have 1 FDA-approved medication, although we are using different medications. So I think we're using at least 3 now. But what's interesting about this data that's been collected is pharmaceuticals can be a very effective approach. So when you look at total weight lost, it can be as high as 10% of their total body weight. And that's very significant. Most of these evaluations were what I would call unimodality therapy. So you're doing one medication or one medication that's a combination. What we commonly do at our clinic is polypharmacy, which is we're using multiple medications. And I think by using that strategy, we're going to see that patients can lose more weight with pharmaceuticals. When you combine behavioral and pharmaceuticals, perhaps you could be in the 15 to 20% total body weight range in a program like ours, but we're going to have to look at this. And then we get into surgery. So I'll stop here for a second and just talk about surgery, because what I find is there's a lot of misconceptions about what we actually do to the anatomy. So you can see here, we have a gastric bypass on the left, and we have a sleeve gastrectomy on the right. What we do on a gastric bypass is we actually make the stomach quite a bit smaller. It's about the size of someone's thumb. And we do that by stapling across the stomach. And we also staple across the small intestine and bring the end here to connect it to that new small pouch. And we also connect it to the small bowel here so that the food flows down the esophagus like it always did into that smaller pouch, and then down the small bowel into this area of connection where it meets most of the digestive juices. Okay. With a sleeve, we're only working on the stomach. So what we do here is we take out about 80 to 85% of the stomach, leaving a sleeve-shaped stomach for the patient. There's no sleeve that goes over the stomach. This is nothing like a gastric band. It is simply changing the patient's anatomy. And interestingly, when you look at these two, obviously they look wildly different as far as the change in the anatomy. But when you look at what they do as far as a mechanism, it's very similar. So now I'm going to talk about some, I think, other misconceptions about surgery. First, I think people have on their mind, patients and referring providers, that surgery is not safe, that it's associated with a high mortality rate, that there's a very high number of complications. And that's actually just not true these days. When you look at probably the worst complication, obviously would be mortality. The mortality rate is about 0.1%. And I'm going to tell you about the adolescent mortality rate here in just a second. But that's less than gallbladder surgery. That's less than hip replacement. And I don't think any referrers have really any sort of resistance to referring their patients with, symptomatic gallstones or significant osteoarthritis of their hip. And there's not many patients dying of those diseases. We are going to have a lot of people die with their morbid obesity with therapy. We now have pretty clear clinical evidence that obesity is actually more risky to patients than even applying surgical therapy to their disease. So very simply, obesity is more dangerous than weight loss surgery. We also have proven over and over again that by applying effective therapy, including surgery to obesity, we can decrease premature death rates by 30 to 40%, which is an enormous number. There just aren't many treatments out there for any disease that can decrease premature death by that rate. So really important is that surgery has a metabolic effect. I used to even, maybe 5 to 8 years ago, when I showed those pictures I just showed you, I would tell patients and providers, hey, our surgeries work by mechanical restriction and malabsorption. And we were completely wrong about that. Okay, well, almost completely wrong. The reality is there's a very significant physiologic effect that these surgeries cause. And I list a couple mechanisms here. The reality is there's probably 60 or more mechanisms by which it works. And once one of us figures it out, we'll probably get a Nobel Prize, but we'll have to wait. But I mentioned 2 mechanisms here. One thing that's been shown evaluating surgery is actually energy expenditure increases after we do surgery, which is very counter to what we see when we take traditional, I would say, diet and exercise type approaches, behavioral approaches. When we decrease caloric intake and a patient loses weight, their energy expenditure tends to go down, which makes it much more difficult to lose weight. Also, we've known for many, many years now that when we apply bariatric surgery to patients, there's this milieu of gut hormones that is affected. Some of them go up, some of them go down. And what actually happens is very simply, the gut brain translates energy and information to the brain in your head. And what your brain hears is that you're less hungry and you are more full and satisfied with less to eat and less to drink. And it happens more quickly and longer, which is an incredibly effective approach to helping patients lose weight. So these are actually data. Another thing that I hear a lot of the time is that there's a perception out there that even though we apply surgery, that most people gain all their weight back. And that's simply just not true. It does happen, but it's actually not as common as I think people sometimes think. These are data that were followed over 10 years. This is an evaluation of Roux-en-Y gastric bypass versus adult controls who received, in quotes, optimal medical therapy, so behavioral therapy. And what we can see in these panels that how effective surgery really can be over a long time. So let's just look at patients who lose greater than 30% of their weight loss from baseline over here. And you can see these numbers are pretty high. You know, you're in the 60%, and we dip down to the 40% or so with surgery. But when you look over to, again, these non-surgical matches, you just don't reach that rate. And another important thing is to look at, well, how about people who lose almost no weight at all, which is, you know, you're less than 5% of weight loss from baseline. The numbers are quite high in our non-surgical matches, but when we look at surgical patients, this is actually quite a low number. So overall, we can see that the weight loss with surgery tends to be pretty high and pretty durable, which is very important to any therapy that we apply. The other thing that we've recognized is that with effective treatment for obesity, including surgery, many diseases resolve at really a tremendously high rate. Again, I won't randomly select, and we talked about diabetes already and its effect on mortality. After a year with Roux-en-Y gastric bypass, that's what this study was. We see as many as 83% of patients who have type 2 diabetes have it resolve, which it still amazes me that number is that high. Hypertension, it's a little wider range, anywhere from 52 to 92%. Cardiovascular disease risk reduction as high as 80%. And we've already talked about mortality rate reduction, 30 to 40% in over 10 years. And then I think one thing we just have to focus on as well is quality of life. When you ask patients after they have surgical or other effective treatment for their obesity a year later, 95% of patients say that their quality of life has improved. Again, when you look at any type of treatment for any disease, how many of those are going to have this outcome where 95% of patients say their quality of life improved? I think that's going to be a really low number. All right, can I say bean counters? Hopefully I don't offend anybody, but for the bean counters out there, because I mean, I'm one of them, weight loss surgery is cost effective. It's been proven, okay? Cost effective ratios range from 5,000 to 16,000 per quality adjusted life year for women. And it's a little higher for men. It's 10,000 to 35,000. And it also depends on the patient's age and BMI. To the insurers out there's not probably anyone listening from an insurer right now, but they recover their costs for bariatric surgery in about 2 to 4 years, and it depends on the type of surgery performed. And so, you know, for everyone listening, I know everyone's thinking, and they're like, but Dr. Sahagian, this is pediatric grand rounds and kids are different than adults, right? When I show you the data, it's actually interesting. They're actually very similar to adults. So there's some very good studies out there now that have looked at what happens when we do surgery on adolescents. And one of them is the Teen Longitudinal Assessment of Bariatric Surgery, Teen Labs. And what we have here is a study of 242 patients. It was 5 US centers. It's actually the largest ongoing observational cohort study right now that's looking at bariatric surgery in adolescents. It included 161 gastric bypasses and 67 sleeve gastrectomies. The mean age of the patients was 17. Their pre-op BMI was 53, which is actually pretty high. I think if you look at most centers around the country operating mostly on adults, it would probably be less than 50. And these patients also had a significant amount of comorbid illness associated with their obesity, usually up to 4. As I said, this study is ongoing, but they do have 3-year data now, and they have a great follow-up rate of 99% in that 3-year data. And what do they find? So they found that the mean weight reduction in these patients is 27%. That's a great number. Also, very importantly, resolution of comorbid illnesses at 3 years, diabetes type 2, 95%, hypertension, 74%, dyslipidemia, 66%. These data look exactly like adults. And they also looked at reduction of overall prevalence of multiple cardiovascular disease risk factors, including dyslipidemia, type 2 diabetes, elevated blood pressure, elevated C-reactive protein. All of these were reduced. Surgical treatment's been shown in adolescents to be more effective than med therapy for diabetes type 2. And also, they asked the same questions of these patients, and they found the same answers. Weight-related quality of life improved. Okay. So let's look at the bad news, right? We want to know about complications. These are super important when we're applying surgical or other therapies to patients. And actually, it's pretty good news. with these complications, the surgical complications, 15% were minor, so nausea and dehydration. 8% were major, 2.7% reoperation before discharge. This is actually similar in adults, at least per these authors. I think it's actually a little lower in adults, but it's pretty close. Mortality rate, exactly the same in these adolescents, 0.3%. As I said, it's 0.1% in adults. One thing that could be different for children and adolescents is this: micronutrient deficiencies postoperatively, iron particularly. You're going to see that this is a theme in these data sets. So 66%, this is definitely higher than adults, okay? B12, 8%, folate, 10%, that's actually pretty similar to adults. So another study, the FABS-5, okay? This was 58 patients. Their ages ranged from 13 to 21, and they all underwent Roux-en-Y. Again, the BMI was high, 58.5. And this is actually, it represents the longest term data we have. So these were patients who were followed anywhere from 6 to 12 years. Interestingly, again, we see very similar data that when we compare it to adults. The 12-month mean decrease of BMI was 22.8. That's really significant. Long-term mean decrease, again, that 6 to 12-year mark, I should say. BMI is 16.9, and that translates to 109 pounds. So that is a tremendous number. Okay, that's going to be a number that's really tough to reach no matter what treatment you're applying, and this is pretty consistent. And again, the resolution of comorbid illnesses was very similar. So diabetes, 88%. Again, it was 7 out of 8 patients. Dyslipidemia, 64%, 29 out of 45, and hypertension, 76%. So still very high numbers. And to look at, well, what were the complications here? What were surgeries that were performed? The most common post-op procedures that were performed on these patients were OB-GYN procedures. The other more common too was cholecystectomy at 21%. There were episodes of GI perforation. These were likely ulcers at the anastomosis, that gastrojejunostomy. So 5%, so 3 patients, and 2 patients underwent laparoscopy. These are pretty in line with adult numbers. And again, we see this theme of micronutrient deficiency. The iron deficiency is high, 69%. Ferritin levels decreased 63, hemoglobin 46. Vitamin D deficiency up to 80%. And when we actually test our patients pre-op, right, I don't know that it's much different. Actually, I think the pre-op incidence of vitamin D deficiency is extremely high. So I'm not terribly surprised by this. B12 at 16%, that's pretty consistent with what we see in adults as well. So conclusion by the authors, I think, is a very important thing to think about. Surgical intervention soon after the diagnosis of severe obesity, so a BMI of 35 to 40, might result in a more complete reversal of the patient's severe obesity and the cardiometabolic risks than when surgery is offered to adolescents who have progressed to higher BMIs. So very simply, we should act as soon as we can. And it's the same thing in adults. If we have a patient who walks in with an 80 BMI, we can only do so much. The damage has been done. If we get to these patients sooner at lower BMIs and when they have less comorbid illness, and we apply effective therapies, we are going to go a lot longer. We're going to give them a better result. We could potentially even get them to ideal body weight. All right, so an additional study was the morbid obesity surgery study, AMOS. This was done in Sweden. It was done nationwide. It's a prospective non-randomized controlled study of 81 adolescents. Again, the age group is pretty similar to what we've seen in these past studies, 13 to 18 years old. They underwent Roux-en-Y gastric bypass. What I really like about this study is down here, they matched their patients, so those that underwent surgery, and then they matched 80 adolescents who underwent medical therapy, and also, interestingly, 81 adults who underwent surgical therapy. So we have a nice way to look at different outcomes. Also, in this study, the mean age was 16 and a half, mean weight was 292 pounds, and the BMI was a little lower here at about 45.5. So what happened? And this was at 5 years. So adolescents who underwent surgery had a decline in their kilograms per meter squared weight, minus 13.2. Adolescent controls who did not undergo surgery, so were given by these authors, they're considered optimal medical therapy. They actually gained weight. So they gained weight to plus 3.3 kilograms, okay? When we look at surgical therapy in adults in matched patients, weight loss was pretty much the same. So these numbers are really close. So maybe in many ways, applying surgery to adolescents can be very similar to adults. Again, the resolution of comorbid illness looks very similar. Diabetes in this group, it's a smaller N, but 100%, 100% resolution. Elevated LDL, again, 100% resolution. Increased triglycerides, 100% resolution. Hypertension, very high resolution at 84%. So really great results. The complications here, as far as all surgical complications, roughly half for laparoscopy for bowel obstruction. Interestingly, in this group of patients, they didn't actually close the mesenteric defects, these areas where bowel obstructions can happen in gastric bypass, and we routinely do this. And I think it's just because the study is a little bit older. I think that could have reduced these bowel obstructions. And also there were some bowel obstructions from adhesive disease. But I think one point of that is it's probably going to be a lower number if we just close those mesenteric defects, which we do. And then when you look at most of the other surgeries, these were cholecystectomies. So 9 out of the 81, okay. One patient did have 2 surgeries. They had an X-lap added on there, and that was just, again, 1%. When you look at some other possible complications, blood transfusions, iron transfusions, it's a low rate. It's 2 out of 81. But again, it's pretty consistent when you look at micronutrient deficiency. I think you guys have seen now that iron ferritin deficiency rate it's been in the 60% in all of these studies. So we need to be very aggressive about treating this postoperatively and also identifying it preoperatively. Vitamin D, a little lower here, 30%. B12, actually a little higher at 22%. Okay, that was a lot. How are we doing here? We're doing pretty good on time. All right. I'm wondering, is there any questions in the Q&A?
No, but there are questions in the chat box.
Okay. Let's see if I can actually open it. Oh, that's a great question. Actually, I see a question about what do they look like regarding when you break down the charts regarding ethnic groups. That's a great question. I wish I had the specific answer to you right this second. What I can tell you is if you go to the CDC website, they have every one of these sets of data broken down in that way. And I wish I had that so I can answer you right now, but I don't. But they definitely exist, and it's at your fingertips. If you go to the CDC website, you'll be able to find that answer. And yeah, they actually, the other question attached to it is regarding is there association with poverty levels? The answer is yes. And again, they've done a very good job of looking at that, and that's again at your fingertips if you go to the CDC website. There's a question about gastric bypass surgery more likely to affect the hormonal milieu than gastric sleeve. And then also, is there data to show the gastric sleeve affects the hormonal control similarly to gastric bypass? The answer is yes. There is data to show that. And I would say it's not quite as powerful, but it definitely does for certain. And as I said, there's probably 60 mechanisms by which surgery works. And one of the other things that's hypothesized is the change in the normal gut flora. And the sleeve definitely does that as well. So I think it's going to be identified that the 2 surgeries are very similar in how they affect physiology. There'll probably be, of course, some differences too, but that's definitely been shown with sleeve as well. I think that was, let's see. What was the youngest age for teen labs? I think it was, I'd have to look back, but I think it was actually 12. There's a question about the longitudinal evaluation of teen labs in 5 to 10 years. And I don't know that that's available just yet. Last question, and then we'll move on. Why do you think the rates of obesity continue to increase so dramatically? Man, that is like the holy grail question, right? So it's multifactorial for sure. I think in the beginning of the talk, one of the major things we have to consider is we're not being aggressive enough about treatment. And also we need to be more effective. And, I think we're talking about that right now. But other things that contribute to this, of course, are patients' behaviors and also environmental pressures. Let's face it, we every exit in our country has a McDonald's these days, right? So we have to look into that. We know there's a genetic component to this, and that's being explored right now. But this is multifactorial, multiple layers to this. Obesity is a circular physiology, so it is very difficult to apply a single treatment to shut that off. It's very much like shock. Shock's killing people today, and it will probably for a long, long time because it's also a circular physiology. It's a very difficult thing to turn off. But the good news about this is we are learning tremendous information about this. And with anything like this, the more we learn, the more we don't know, right? All right, so what I'm going to do is I'm going to move on. So I promised to introduce our weight and wellness team. So let's do that. So who are we? So we are a completely integrated program. I think most programs treating obesity around the country in the mid-2000s were very surgically driven, okay? And one of the major goals that I've had and all of the folks who are associated with our weight and wellness program is making sure we can become integrated, and we are now. And what that means is we have a very diverse set of skill sets in our team, which starts with a diverse set of skill sets with our physicians. And so we have adult and pediatric obesity medicine specialists. 2 of them I think are here today, which is great. We of course have bariatric surgeons like myself. And then you can see the list of our team members. We have, again, a very wide set of skill sets, and that is by design. We know obesity. To treat this effectively, we need each and every one of these people. And our patients see each and every one of them. Okay, so they're going to see these team members as part of their treatment. So what's the role of a pediatric medical bariatrician? As I said, I have 2 of them here today, so they can chime in at any moment, but they've seen these too. So in our program now, all the patients see an obesity medicine specialist first. And there are huge benefits to this. And one of them is that it allows for the most critical patients to be streamlined to surgery if that's necessary. But there's many other things that this is a huge benefit. So patients and families can work with the obesity medicine specialist, and they really develop an awareness of how their bodies can signal when treatments are not as effective. And that's critical because every treatment has a limit. No matter whether it's surgery, whether it's pharmaceutical, whether it's behavioral. And if patients don't understand triggers, we're not going to have as good results. What we found too is our obesity medicine specialists are an absolutely critical resource to all of our team members so that everyone can understand the disease of obesity. So we all have a better understanding of it. All of our providers, all of our team members, and our patients, which is critical to success. All of our patients work with the obesity medicine specialist to look at their medication regimen and potentially revise these medication regimens if they are on medications that are obesogenic. This really requires a lot of coordination. So, our specialists within our weight and wellness program are going to work with all of you with your patients, and our adult specialists do the same with our adult patients. The obesity medicine specialists also manage diseases 6 months before and really after surgery as well. These include diabetes and hypertension because we really want to maximize this treatment around surgery if that's what we're going to choose for treatment. And they are also using medications now. As I said, unfortunately, I wish there was 100 medications approved. With adults, it's 9, and with kids, I think it's 1. But I think they're using up to 3 medications in the appropriate circumstances. So here's our clinic. I think we've been in our facility in South Portland now for about, well, not quite, maybe we reached a year now. I think we're close. but we have a state-of-the-art facility. It's a beautiful facility. We have all the technology we would ever need. So, and also our patients can come to see all of our team members in one place. And that I think is really important. And what is also important is I think our providers can work very close together. Our pediatric obesity specialists are one door down from me. Our adults are two doors down. So I walk down the hall and I see these people every day, and we can collaborate in a much easier manner. And I think we've seen this really have an effect over time. You know, I think when patients have a consistent message, they really can do a lot better. So let's talk about our philosophy and approach to care. So what's our philosophy? So it is definitely a comprehensive approach. We're managing a chronic condition, a disease, obesity. So there's no cure for that. We have to help patients manage it. And we know now that this is going to require multiple tools. It's not just one thing. And in fact, unimodality therapy is really not going to be that effective. So we use many tools, and some of them are listed here. You know, of course, we talk about diet, we talk about physical activity with patients, but now we focus on some other things as well with everyone. And that includes, well, how well are they sleeping? Do they have any issues there? Because those things can definitely contribute to having difficulty losing weight and gaining health. As I said, changing medications can be critical. Adding medications that are specifically directed towards the treatment of obesity can also be very effective. And of course, you've seen the data on surgery. One of the major things that I think is just absolutely critical, and you remember the pyramid and the basics of trying to treat obesity, we have to look at behaviors. We have to look at patients' relationship with their food. And I think all of our patients will tell their providers that they learn that here. They really do. And it's critical. And the other thing too is really looking at trying to uncover the specific metabolic changes that have occurred in each individual patient that has contributed to their obesity. And that's really important to take this approach, because if we take that approach, we can really customize their care and hopefully give them a better result. And it's not going to be too long that we're looking at value-based care. And obviously we're going to have to be effective and also very fiscally efficient. So approach to care when we opened. And we opened, well, I'd say about 3 years ago now, when we really looked at integration and really having the team members that we have right now. So we've always been physician directed, which again, I think is a huge benefit to patients when their treatments are really all looked over by a physician. Our program is definitely a high frequency intense program, and patients can see us really more than twice a month. We've definitely leveraged technology more and more, like we're doing right now. It's been very effective. So we definitely use telehealth appointments, but the intensity level is important to success. We do, of course, want to have results for patients quickly and efficiently. And again, that fits into a new model of value-based care whenever it arrives. We definitely look at individualized treatment models for patients. There are, of course, very consistent themes in this, but I think all of our patients really are looked at as an individual. And again, I think this is absolutely essential to success. Group therapy has been very effective in the past. We actually have the facility to do this in a very effective manner. And unfortunately, COVID has put a little bit of wrench in that. But I think once that is in a better place, we are definitely going to be able to leverage our facility and use group therapy in a very effective manner. And from the beginning, we've always used medications and surgery. So what's going to happen in 2021 and beyond? So I think we've really taken a new focus on trying to change our vocabulary. Again, like I said, most programs in the early 2000s to mid 2000s were very focused on surgical therapy for obesity. And really, we try not to look at it that way anymore. We're not looking at it surgical versus medical. It's really just a patient who is referred to us to treat their obesity. And our approach is to help them with that and help them gain health, which is going to be absolutely critical to their success in the long term. Everyone's care, as I said, begins with a medical provider who's trained in obesity medicine. And really the role there is to help educate patients, because the vast majority of our patients don't really have a clear, concise picture of everything that we can apply to treat them for their obesity. So that first visit is really all about that, to really explore what we could potentially offer a patient and just work them down that path, to help them down that path. We're definitely now evolving the family approach. We know this is familial. We know obese parents can very commonly have obese children. And to take that approach just makes sense. And the other thing we're working on is a health maintenance care pathway. So for patients who come to us and we see them for many years and get them in a good place, we have to develop a pathway to really reintroduce the patient to the community and who's taking care of them out there. Because as I said, there's probably going to be 100 million obese people in our country very soon. And there's no way we can see them all here at Weight and Wellness. So, I mean, I'd love to, but we can't. All right. So I've made it, we're good on time. So I've made it to our end now of one of surgery at Weight and Wellness. And I'm very happy to say it's been, I think, a very, very significant success story. Okay. So we first saw our patient, MA, in 2018. He was 15 years old. His weight was 437 pounds. His BMI was 65. And we diagnosed insulin resistance, sleep apnea, hypertension, depression, and elevated liver enzymes. And he, of course, worked with our multidisciplinary team over his course. I saw him in January of 2019, and you can see that his weight was 445 pounds. His BMI was 65. And we commenced the workup for a sleeve gastrectomy. And he actually had his consent visit about 8 months later, and we were ready for surgery. But again, we have a multidisciplinary team, and some of our providers identified that we perhaps hadn't completely optimized the patient. And so we worked on things like his anxiety, depression, and he actually developed some abdominal pain, which we ultimately determined was most likely from reflux. We worked a few more months, and then he had another consent visit in December and underwent, I guess I should have some like fireworks or something go off, but he underwent his lap sleeve gastrectomy in December. And then what happened? So what happened is very similar to what you saw in the data that I presented in those studies. So we had our first follow-up in January, and at that time his BMI was 60 and his weight was 409 pounds. So he lost between 20 and 30 in the first couple of weeks. And then he continued to follow with us, and that's what our patients will do. Now, I listed visits here with the pediatric bariatrician and myself, but realized this patient was seeing the entire team, the social worker, the dietitians, and other folks in our clinic the whole time, okay? But you can see, let's shift down to maybe a more end result here. So office visit with myself in November, which was, I think, about 6 months later. BMI was 49, weight was 333 pounds. And he had lost 112 pounds. That's about 25% of his total body weight. And actually that was 11 months, sorry, it was not 6, but at 11 months, 25% of his total body weight. And we of course look at his laboratories, and his most recent CBC, ferritin, vitamin D, B12, and folate are all normal. So I think hopefully we kind of listen to the data, and we're being very aggressive about treating things like iron deficiency. And obviously that would be a little less prevalent in a sleeve gastrectomy. He did have a recent telehealth visit with one of our pediatric bariatricians. He's now 18 years old, and they're actually adding another medication because he started to have cravings. And at least and looking at those notes, he's having a good effect with the medication. We know now that his hypertension is resolved. He's had improvement in his insulin resistance. We're actually getting him to get his sleep study repeated so that we can prove that likely his sleep apnea is also resolved. And he has a job at Bath Iron Works. So if you ask this patient if his quality of life improved, I think he will emphatically say yes. It was really fun to see him at 11 months. So this is Harvey Sugarman. So he's the godfather to many of us in surgery and regarding treating obesity. And this is something he said in the foreword of our textbook. We now have a textbook for obesity surgery and for that matter, treatment. So it's really intended for surgeons, medical providers, and also allied health. But I love this statement. Our field has progressed from a few surgeons pioneering a narrow and controversial path to thousands of surgeons and integrated health teams from around the world providing care for patients affected with severe obesity. And that's reality, which is great. This has changed so drastically since really kind of the year 2000 and into now. So if anyone's wondering, if there's a couple things you can look at to really understand, who's a patient that we should consider for surgery, who's an adolescent, who's a patient that we should refer to Weight and Wellness. So these are two great documents to look at, and it won't take too much time to go through them. Probably, honestly, for most less than an hour, but they are really rich with information and well worth looking at. I think with that, so I add this one more time so you guys can text so you can prove that you attended. And I guess with that, we can let's look at the chat. What else is there? So I have, with alignment, how is Weight and Wellness aligning with or similar to or different from Southern Maine Health Center? So that's a great question. And I think what's mainly different right now is that they don't have a robust medical component, but we are going to fix that very soon. And the goal, and this has always been, I think, all of our goals at Weight and Wellness, is that we really want to regionalize treatment for obesity in Maine and northern New Hampshire. And that's what we are going to do. So that will start at Southern Maine, and then it'll progress to many other facilities across Maine and northern New Hampshire. So we have every intention of making this look the same everywhere. But it's a great question. Let's see. And I guess someone already, looks like Carrie chimed in already, and she's actually absolutely right. Insurance hurdles from Ian. So if you mean insurance hurdles regarding getting them weight loss surgery, I think we are going to run into this a little bit. When you look at those studies, interestingly, one of the big things that was identified was when they worked through the process of getting those patients ready, up to 49% of them were having issues with insurance. And I think,
can I chime in? Is it okay if I chime in here? But we've already had an adolescent who we tried to get approval for insurance for bariatric surgery at age 16, and we had to wait till she was 18. And I sent them all kinds of articles about how effective it was. And what I basically heard back from the insurance company was, we're not arguing that it's medically appropriate, we just don't have to pay for it. And we have the same problem with some medications. So it is a challenge, and you could argue, I think, that that's part of that comes from the bias against obesity and the people who have who carry extra weight. It's an understanding and it's starting to get people more on board with the real belief and understanding that obesity is a disease that deserves treatment, just like hypertension and diabetes, and it's a challenge. Hopefully, it'll get better.
I think it definitely will get better. We already have accreditation for surgery in an adolescent as part of Center of Excellence, MIBISQUIP, and I'm certain we're going to see a committee very soon about this. There's a very well-developed committee in the ASMBS looking at issues with insurance in adults, and I'm certain that this is going to be a big part of the next few years because, as I've said, what the data shows is we should intervene as soon as we can, and to leave these adolescents out there, to allow insurance companies to do that, we just can't do that. We have to be aggressive.
I just want to, if I can chat for a second.
Sure.
I think one of the most important things that you've said that I just really want to emphasize around getting people done early is the fact that we actually can resolve a lot of the comorbidities. So instead of a 16-year-old developing diabetes and then having diabetes for the next 10 years until somebody decides to do bariatric surgery, if you can get them away from that at a much early age, there's all those complications that you're preventing. And that really was the thing that convinced me a number of years ago doing this work that bariatric surgery was appropriate for adolescents, because like so many people, I was a little bit hesitant around, is this the right thing for adolescents? What do we know about their long-term outcomes? And what we do know is that we're going to prevent a lot of serious long-term outcomes by doing it early. And for me, that's really an important part of why we want to do this.
I think that was a really great statement. I mean, prevention, and also once this physiology is set, so once a patient reaches a certain BMI, let's say, you saw a lot of the studies, often these adolescents, you're talking about BMIs in the 50s. Once you get to physiology like that, it's really difficult to reverse it, no matter what we do. So yeah, I mean, I don't know. I don't think I can stress it anymore. So let's see what else is in the chat. There's a question about use of technology for continued intervention with kids, cell phone, messaging, email. I mean, I know we've definitely leveraged telehealth. That has been a very effective strategy. I'm not sure that we've leveraged those other, but maybe we have. Maybe Pam and Carrie can talk about that.
I'd love to do more technology wise that we haven't. I mean, the Zoom visits have been incredible. Our show rate is really good for the Zoom visits, and
Right.
There are days where patients would cancel because they can't get there, but they switch to Zoom appointments. And I'd love to do other things. I mean, we're doing our cooking class. We're doing a virtual cooking class, and they're using a learning platform called Thinkific, and that's been going pretty well. But yeah, I'd love to do more, and I think that's it's that balance of seeing the kids that need to be seen with your time versus creating new strategies. But we should. It would be great to do more.
And I see a question about weight loss apps. There are numerous ones. There are many examples. A lot of our patients use them to track what they're eating, and they can get into very significant detail. If that's what you're asking, I think you are. That's definitely out there. There's many different options. And maybe you're asking if we use one specific for our patient. We don't. And then I see, let's see, what is the lowest BMI and lowest age that you think surgical intervention is appropriate if other medical modalities prove not effective? So I think, gosh, I want to address that in, I think, a little different way than people expect. I think the tendency is to think that we should sort of always think about exhaustive measures before applying surgery. And I think we should think a little different about that. I think we should really think, as we've said, early on, potentially applying surgery. Do I have a specific age in mind? The answer is no. I think these days we're going to look at individual patients and see what we think is appropriate. Hopefully that helps answer your question. I think that the theme should be.
The AAP, I was going to chime in. So the AAP doesn't actually have a lower age limit, I don't think, for surgery. No. So, I agree with you, Kirk. It's just sort of like looking at the whole picture, looking at the situation. Obviously, even though surgery is going to be the most effective thing, sometimes for the really young kids where you're questioning how can they consent, if you can at least maintain their weight with some of the medications and buy them a little bit of time, hopefully you won't be doing as much damage. And but yeah, there's no lower age limit. So.
And also, at least
not that we do them here. We're not going to be doing surgery here. I mean, we had a kiddo that Mike Dedekian was seeing, and is before we started our surgery program, and we tried to get him down to Boston. He sent him to me just because I was there more often, and we tried to get him down to Boston, and it was just impossible for the family. And he was 10 at the time, and Boston said they hadn't done anybody that young for bariatric surgery. And subsequently, I've been more confident with the medications, and he's lost a lot of weight. He's lost 40 pounds. I saw him last week on medications. So he'll probably need bariatric surgery, but we'll be able to do it now. He's a couple of years later. We'll be able to do it when he gets a little bit older here at Maine.
There's a couple more questions in the Q&A that I just opened, so I'll try to address those. There's a question about what physically happens if a child continues their current eating habits post-surgery. And I think that must be a question. Well, is there something terrible that's going to happen if they sort of don't comply to everything that we say? And this happens in adults. I mean, if you think all of our adults listen to every word we say, the answer is they absolutely do not. So there's not much they can do to really put themselves at risk. We all surgeons have the story. I have this story myself of the one patient who literally tried to eat a bucket of chicken like 3 days after their surgery and blew out their pouch. So, it's possible. It's very unlikely. It's very unlikely that they're going to do something that's going to really put them in danger. Now, if they don't follow the recommendations, they very well could have more symptoms post-operatively and also not lose as much weight as we want them to lose. So those things can definitely happen. I think the only way to combat that is to, again, have very frequent visits, which we do. And I think as we've leveraged telehealth, it's easier to do. So, that's, I think, what we can do to avoid problems that would be associated with non-compliance. Do you guys have anything to add to that?
Just to chime in, also to be talking to patients about cravings. Our patient that KIRK presented that has done so well after bariatric surgery. Initially, he wasn't very hungry. As he got closer to a year out, he started getting more hungry. Having those conversations with the patients to say, like, okay, if you're now starting to feel so hungry that your eating feels like it's not as healthy, there's things we can do medication-wise, therapy, depending on what you think is going on with the patient that might be causing it.
So there's a couple other questions. One is, I recall some pediatric bariatric programs performed upper endoscopy prior to surgery, perhaps an esophageal impedance study. What is the current standard of care for pre-op GERD evaluation in pediatric and adult patients? And how does a GERD diagnosis affect postoperative outcomes? And I think this is it's not different in adolescents when you compare it to adults. I like to do a preoperative upper endoscopy on every patient, mostly to evaluate the anatomy. And we do that we will do that on our adolescent patients. And I think if you have a GERD diagnosis, then you're probably a better candidate for a gastric bypass than you are a sleeve. And so we actually have a patient currently that has pretty significant esophagitis and obesity, and they were going to be worked up for a NIST, which is exactly the wrong move. We need to do a bypass on that patient, and that's what we're going to do because they have pretty severe GERD and esophagitis and obesity. Hopefully that answers the question. And Dr. Mallory actually made a very good point that I'll share. He asked that I mentioned that morbid obesity in an adolescent poses a greater risk to their life than smoking 2 packs a day. And he's absolutely right. Obesity is equal risk to smoking in adults and children. So that's a great point. So I think everyone out there is kind of, scared for their patients who smoke. I hope we can get a little more scared for our patients who are obese. And I think I ran over time, so. But thank you so much for inviting me. It's always a pleasure to talk about this. It's, again, near and dear to me. And if anyone has other questions, gosh, you can email me anytime, or, you can just find me. I'll answer. I'm happy to answer questions, and we all are.
Thanks so much, KIRK.
My pleasure.
Thanks, that was great.